So just to introduce myself, my name is Ben. I did my prelim year here, a radiology year at Emory before I decided that the dark side wasn't for me. And I came over to medicine, transferred this year, second year currently. Today, hopefully my PowerPoint and my screen sharing isn't working, but hopefully we'll get a PDF of my PowerPoint running soon. In the meantime, I have this awesome little whiteboard that will go over some anatomy, some chest x-ray anatomy. You guys can show me some wonderful drawings. We'll go over some physiology of what happens on actual chest radiographs as well. Okay, everybody ready? They got their colored pencils. I'm seeing lots of cameras. There's still some that aren't open. I'm gonna be calling on those people, by golly. Okay, you guys are ready. Let's do it. So first, it's important to we'll just go over some chest x-ray basics. If my PDF comes up, we'll do some abdominal radiographs, and I had some CTs that were pretty cool that I was gonna run through and show you guys how to read, but I can't figure out my screen sharing, so we might have to ixnay on that. For chest radiographs, let's draw some basic anatomy. So I want everyone to start off by just drawing the left lung. It's gonna look something like this. It's beautiful. We'll do a little diaphragm. Another little diaphragm. We'll go back up, draw the right lung. Man, that is a beautiful lung. Let's see what you guys got. Then we're gonna draw the heart. We'll draw the right. Oh man, Nikki's got a good one. I actually can't see it. Oh man, Sarah's got a great one. You guys are way better artists than I am. We'll start out with the right heart. So I'm gonna use blue because it's deoxygenated. I'm just gonna draw a little oval circle right there. We're gonna draw the IVC here, the SVC coming up. And then this is gonna be the right atrium here. So this is important. This heart border right here is the right atrium. So we're gonna label that RA. And then the right ventricle is gonna be here. That's gonna be kind of the frontal part of your radiograph. Then we're gonna take out our red. We're gonna draw the left ventricle and the left atrium. Left atrium is gonna be right here. Left ventricle is gonna be right there on a frontal radiograph. So the sides that are actually gonna be, the parts of the heart that are actually gonna be touching the lungs on a frontal radiograph are gonna be the right atrium, the left ventricle, and the left atrium. The right ventricle doesn't actually touch, which is important when we get to kind of like some silhouetting where we're trying to identify where consolidations are. Going up, we have the aorta coming up. We have the little aortic line that's gonna go down here. Then we have the pulmonary arteries coming out here from the right ventricle, kind of making up the hyla, with the trachea, which is going to come down here. Then you got your carina here. Let's see everybody's drawings so far. Are they beautiful? Mine's pretty bad, I'm not going to lie. And then for the lungs, we have the horizontal fissure. In the right lung, we have the oblique fissure. And then in the left lung, we have another oblique fissure. Everybody got that down? Then I wanna point out some important lines, but first, I know this is a pretty poor substitute for a chest radiograph with my screen not. There's various different ways. Let's see, I saw Kevin speak up earlier. Is he still on?
Yeah, I can talk you through.
Yeah, talk me through it.
I usually start with the alphabet.
Yeah, the
Um,
alphabet's a good place to start.
so A, B, C, D, E. I look at the airway first. So I start by looking at the trachea and seeing if it's, well, I guess I should probably say that I should start by making sure I know if I'm looking at a PA or AP, and
Mm,
what the
great point.
penetration and
Great point.
quality of the image is. Trying to get ready for MICU again. And
Yeah.
then after that, would take a look at the airway, take a look and see if it's tortuous or if it seems straight in midline, take a look at where the carina is. And then next would look at airway, bones, see if there's any rib fractures, which I'm not great at and often glance over way too much. Cardiac silhouette, taking a look at where the heart borders, how they look like, whether they're crisp or not, and whether I see any evidence of a like what the size of the cardiac silhouette is. And then diaphragms, taking a look at whether there's elevation or whether kind of how they look, and especially where there's crispness and the costophrenic angles as well. And then E is, I think, supposed to be everything else, but I use this time to like kind of see what draws you to it, and especially with an eye on the lung fields themselves.
Great. And I think that you bring up a really good point that I want to get across to everyone. I think the ABCDE method is perfect. Kevin did a great job of going through that. Some people like to add the acronym doctors to the ABCDE method, with D being details, which is kind of what Kevin went through. Making sure you got the right patient, making sure you know what view it is in. Is the patient erect? Are they supine? Is it AP, PA? I was really confused about what AP was and what PA was back in the day. AP just basically means that you're taking the radiograph and you're shooting the beams anteriorly. They're gonna hit the heart, and the patient's back is gonna be up against the board, the screen. And so the radiographs, the beams are gonna keep traveling back, and it's gonna make, the thing that happens with that is it makes the heart look a lot bigger. Whereas if you have a PA, the heart's gonna be, the patient's gonna be right against the film. And so the heart's gonna look a lot truer to size. The mediastinum might also look a little bigger on the AP view. So that's kind of a tricky thing that some people can get messed up on and call cardiomegaly or pulmonary edema when there actually isn't any. Other things that people can get messed up on with the D for details is, you know, talking about if they're erect or supine. If someone's laying down and they have the lung here, you might see like this radiograph, and it might just look all fuzzy, and you're like, oh man, what's going on? Maybe this guy's got ARDS, I have no idea, but really they might just have a pleural effusion that's kind of leveling out down here. So it's important to know. Also, it's important to know because if you're looking for a pneumothorax, if they were erect, you'd look for a pneumothorax up at the apices. If they're not erect, you might look for a pneumothorax here. You might see something like the deep sulcus sign, which we can get into a little bit later. Questions on that? The other letter in the doctor's ABCDE is RIPE. And that acronym just looks for rotation, looks for inspiration. You should have about 6 anterior ribs, which are gonna kind of run like this. So you want 6 on a good film, and then about 9 posterior ribs. These are gonna run this way, going down. And then P I already said position, right. I can't remember some PowerPoint. Just something I want to point to. Is looking at the trachea. This angle in between the lower right main stem and the left bronchus should be about 110 degrees. If it's wider than that, if it starts flattening out, that can mean that there's some lymphadenopathy that's kind of pushing up against the carina and splaying it out. Another important point to look at is here, there's this line called the, and on this side, it's called the paratracheal line, and it's should be about 4 millimeters or less. If it's wider than that, it's the line in between the trachea and kind of the esophagus and some of these blood vessels here. If it's wider than 4 millimeters, a lot of time there can be some adenopathy, there can be a clot, there can be a mass. That's an important spot to look. Then we get to our borders section, which Kevin did a great job going through. So important to know the parts of the heart that you can see. Remember, I was talking about right atrium, left ventricle. We look at the cardiophrenic and the costophrenic angles. If they're blunted or there's a meniscus sign, you might have a pleural effusion. And then looking at the borders as well, there's something called this, oh, here we go, we're in business. You guys, it was hard to keep up just doing this from my head, I'm not gonna lie. Let's see where we're at. It might not work actually anyways, I might have spoken too soon. It looks like, is there insufficient data, Lauren?
There is insufficient data, sorry.
That's
yes.
Okay. I was just joking. I had this prepared as a chalk talk, so this is gonna be great. We're gonna keep going. So silhouette sign. Does anyone know what a silhouette sign is? While I'm talking about the borders of the heart? Anybody?
When you can't see the edge of the heart, so you can't see a clear, crisp border. There's something blocking it.
Great. I can't see who said that, but that is awesome. And the reason that happens is, you know, radiographs are pretty stupid. So they're just reading the different densities. Oh, look at that.
Okay, now can you guys see this? I think it's finally gonna work. Okay, and I don't know where you want me to advance to, but.
And you guys probably can't see my mouse on here pointing
No,
out,
so
right?
yes, you'll have to bear with me driving, unfortunately.
Okay, let's just keep going through.
Okay.
We kind of went through that anatomy. You can go to the next slide. This is the details I was talking about. So the RIPE acronym, the rotation, the inspiration, picture exposure, we went through that pretty good. You can go on. This is just kind of some secondary areas that a lot of people miss. It's important to look at the apices of the heart to make sure you're not missing pneumothoraces. People forget to look, the diaphragm as a dome. And a lot of times there can be pathology on the other side of the diaphragm that you can see, and people forget to look at through the diaphragm and also through the heart. You can see consolidations through there. You can go to the next slide. This is just probably a better visualization of the AP and the PA view. So you can see how the AP can make it look like there's cardiomegaly. Next slide. And this was a supine film, so you can kind of see why it's important to know if the patient is erect or laying down. This is a pleural effusion that is kind of layered out all over the lungs. You can go to the next slide. Next thing in the doctor's acronym, doctor's ABCDE, is the soft tissues. People often forget to look at this. So looking for subcutaneous emphysema, a lot of times you can catch fractures. A lot of times you'll see rib fractures, and that'll make you take a closer look and check for pneumothoraces. You can go to the next slide. Airway, we talked about this pretty good. You can go to the next slide. Next slide. This is just a lateral radiograph, so you can see the borders of the heart there. You have the right ventricle in the anterior portion, the left ventricle in the posterior portion. You have that retrocardiac space behind the heart that you can get masses in. You can also get masses in the anterior portion. I'm sure you guys remember the 4 T's. I won't go into that. And then you have the spine in the back. If you get, the spine as you go down should keep getting more loosened. And that's just because if you take a look, if you're shooting a beam through me, there's a lot of soft tissue that you're going through at the apices, but as you go down, your lungs get bigger. And there's more air, so it should get more loosened as you go down. If it doesn't get more loosened, there's something called the spine sign, which we'll probably see an image later, and that can mean that there's an opacity down in the lower posterior portions of the lungs. Next slide. Okay, so then we want to look at breathing. We look at the vascularity, look for any lesions. For the sake of time, I'm just going to keep going on. We'll talk more about this later. The circulatory, the heart should be about, less than 0.5 the size of the total width of the diaphragm. And then I talked about the heart borders already, making sure there's not a widened mediastinum. Next slide. And then you look at the diaphragm. You look underneath the diaphragm, make sure there's no air underneath. Next slide. This came up again. That's okay. Next slide. And then E is you look for extras. So all your tubes, all your lines, just anything else. Next slide. This is a kind of busy slide, but it shows where the correct positioning of all these tubes. I think this is an important one for internists because a lot of times you'll be putting in lines, nurses will call you and they'll be like, yo, can I use this NG tube? So take a look at this. I can't really point to anything, but you see the kind of brown NG tube. The most important thing with those feeding tubes is making sure it goes past the blanking on the name right now, the gastroesophageal junction, right at the edge of the diaphragm. It should go 8 centimeters past, and it should actually kind of point towards the duodenum. If it goes past like 4 centimeters, it's probably okay. You want to make sure it's not coming back up into the esophagus, or sometimes it can go into the lung through the right main bronchus. We'll see a picture of that later. For the dialysis catheters, they should actually be kind of in the right atrium because they're very high flowing lines. And then the ET tube is another important one you guys will see. That should be about 4 centimeters up from the carina. Perfect, there's the carina. And we'll see some pathology when that's placed too low. And then central venous catheters, you want to make sure it's not going into the subclavian vein there that you can see. It should kind of be in the cavoatrial junction or the high SVC. Another place that it can get into is the Azigus Vein, which we'll see on a slide coming up. Next slide. I think this is out of order. We'll go back to this, but next slide. Next slide. Next slide. We're just starting over. I think my first one didn't save. Sorry about the troubles with this. Perfect. Can someone tell me what's wrong with this picture? There's a NG tube. This is an NG tube placement. Are you going to tell the nurse you can use it? Great.
Lungs. The trachea.
Yeah, so it's going in, it's kind of looping in the right main and then going back into the left bronchus there. So that's not great. You're going to give the person a pretty big aspiration pneumonia if you do that. Next slide. Okay, what about this one? What do you guys see? So yeah, the NG tube is too low. It should be advanced because it's just barely past the diaphragm. And then what do you guys think? There's another tube in there. Yep, Anisha is looking at it. The ET tube, endotracheal tube, is kind of going into the right main stem bronchus, and it's causing a ton of atelectasis. Like the whole left side of the lung is pretty atelectatic from the endotracheal tube going into the right main stem bronchus. So that needs to be pulled back. Next slide. This is kind of the same thing. Next slide. What do you think about this one? The one on the right is before, the one on the left is after. Just kind of same thing. ET tube is going into the left lung. That's not great. Do not say use this. Always get radiographs after you place an NG tube. Next slide. Okay, now just talking about radiographs. They're pretty dumb. I always thought that I just like this beaker glass because it kind of shows what density things are going to show up on your radiograph. I was always really stupid before, you know, even like a year ago, and I was like, oh, fat is, you know, I can see fat, but I can see through water, so I should be able to see through water on a radiograph. No, it's all about density. As you can see, bone is white, water is actually pretty white too, and then you got your fat and your air. Next slide. And then another basic thing that's pretty important when you're reading these radiographs is to look at your airways, to look at your heart, to look at your fissures, to look at the diaphragm and see where things are pushing, see where things are pulling. Masses, pleural effusions, consolidations, pneumothoraces, they're kind of gonna push structures away, and then atelectasis and fibrosis are gonna pull things in. Next slide. Silhouette sign, we were just starting to talk about that. Someone described it. Basically when things are touching, next slide. Oh, that didn't show up. Next slide. When things are touching, the borders are gonna be obliterated. You want nice, crisp borders. And if borders are obliterated, you can kind of tell where a consolidation is. So this is just kind of a chart that shows, you know, if you can't see your left heart border, then there's going to be a consolidation or a mass in the lingula of the left lung. If you can't see the left hemidiaphragm, it's going to be the left lower lobe. If you can't see the right hemidiaphragm, it's going to be the right lower lobe. If you can't see the right atrial border or the right heart border, it's going to be the right middle lobe. If that makes sense to everyone. We'll see some examples on the next slide. Oh, that is kind of what it looks like. Okay, here's someone want to tell me what they see. Where do you guys think this consolidation is located? For the sake of time, I'm just going to tell you it is, it's actually, yeah, the lingula and the left upper lobe. I guess the lingula is kind of the left middle lobe. There's a right middle lobe, but no real left middle lobe. But yeah, this is a left upper lobe consolidation. You can see the left heart border is opacified. The lingula could be in the lingula a little bit, but the lingula is more kind of behind the heart a little bit. Next slide. Where do you guys think this one is? You have a nice lateral radiograph that kind of helps out. Yeah, so right upper lobe, and that's going to be posterior segment of the right upper lobe if you see on the lateral radiograph. Great, next slide. What do you guys think about this one? So we're looking at our borders. Heart looks good. Diaphragms. What do you guys think about the right diaphragm? Yeah, so right lower lobe, posterior section. And if you can see on the left side, there's that, see how the spine is getting loosened, and then it's not loosened at the bottom. That's called the spine sign, tells you that there's a consolidation there. That could be a consolidation or it could be atelectasis. I'm not exactly sure on that one. Next slide. Okay. What do you guys think about this one? This is actually a left, yeah, great. Left lower lobe. You can kind of still make out the left hemidiaphragm, but not as well as the right hemidiaphragm. Notice how you can really make out the left heart border. So you know it's not a left upper lobe. And then if we get the lateral, you can definitely see it's the left lower lobe and its posterior segment of the left lower lobe. Next slide. Does anyone know what these things are, what they're called? Yeah, these are air bronchograms. You can see them on radiographs when basically it just highlights the bronchioles and bronchi. It's just air with consolidation next to it. They're called air bronchograms. They're pretty nonspecific. You can see them in consolidation. You can see it in atelectasis. You can see it in edema. But it can be pretty helpful when you're looking behind the heart. Sometimes you can see these air bronchograms where you wouldn't be able to see a consolidation very well otherwise. Next slide. Okay, let's talk about pneumothorax. Next slide. What do you guys think here? When I'm looking for pneumothoraces, I want to make sure I know which position they're in. If they're erect or if they're supine, because I'm going to look for the air is going to rise. So I'm going to look for the pneumothorax in different places. I pay special attention. This one's erect. I pay special attention to the apices. This one, you can see this kind of line on the left lung, which looks suspicious for pneumothorax, but if you notice, it's like pretty thick and it actually goes across to the other side of the lung. That's actually just a skin fold. A lot of people can get tripped up on that. And you can see if you look really closely, we're not really able to zoom in on this, but there's actually lung vasculature that goes beyond that line, telling you that, no, this isn't a pneumothorax. Next slide. You can compare and contrast to the right picture, where at the right apical portion of the lung, you see no vascular lung markings, and you see a very thin pleural line. Notice how thin it is compared to the left. And it doesn't go across to the other side. Next slide. Okay, great. What do you guys think this is? It's a pneumothorax, perfect on the right side. That lung is just collapsed all the way down. Anesthesia is all over it. Awesome. Pay special attention on pneumothoraces to mediastinal shift to the trachea. You can see on the bottom of this right how lucent the diaphragm is compared to the left. And more subtle cases of pneumothoraces, if they're supine, you can see the deep sulcus sign, which I think we'll see in a little bit. Next slide. Okay, this right here just shows kind of the deep sulcus. It's kind of off screen a little bit, but compared to the left side, you can see how deep that sulcus is. And then there's also, this is called the double diaphragm sign, where you can see both the anterior part of the diaphragm and the posterior part that is kind of just outlining the diaphragm with air, which can be a sign of a pneumothorax. Next slide. Okay, atelectasis. There's some atelectatic patterns that I want you guys to be familiar with. Next slide. This is just your run-of-the-mill right upper lobe atelectasis. Sometimes this can happen if there's like a mass, a bronchial mass that causes collapse of a right upper lobe. So it's important sometimes to rule out malignancy if it doesn't resolve. As you can see, when we talked about kind of the paying attention to the tides, you can see that everything's kind of pulled in. That lung has lost a lot of aeration, and the mediastinum is shifted over to the right as well. And if you see that the horizontal fissure is actually just like rotated clockwise up, it's almost at like the 11 o'clock position instead of being in the 9 o'clock position, just going from here to here. So that's just what right upper lobe atelectasis would look like. Next slide. Does anyone know what this sign is called? This is called Luft-Sickle sign. It's a German name, which Luft means air, and then Sickle means sickle, which, you know, those things you chop wheat with and whatnot. But if you see in the left lobe, there's kind of this crescent of air that's hypolucent. That's actually the left lower lobe that kind of creeps its way up there. You can see on lateral projection. And this is just complete left upper lobe atelectasis. You can see there's kind of some patchy looking infiltrative lesions. This person probably has some metastatic cancer or something blocking his left upper lobe. So left sickle sign, left upper lobe atelectasis. Next slide. There it is, that beautiful word. Next slide. This, I know you guys all know this, but I had to show you a pleural effusion. So this is just left pleural effusion. You can see the costophrenic angle is just totally obliterated, and you can see this little meniscal lip coming up here. This is called the meniscus sign. It kind of looks like what you'd expect if there was water in between lung and pleura. Next slide. Okay, someone want to tell me what they see on this radiograph? Air, Uder, the heart. I believe he meant under, but we were speaking a little German, so Uder is appropriate. Yes, there is air kind of outlining the heart. And this is a sign that you want to look for pneumomediastinum. You can also see air under the heart. Yes, that is perfect. You can also sometimes see air that outlines vasculature, or you can see air that's kind of dissecting up the neck. And sometimes another sign of it, if it gets really bad, you can see a lot of subcutaneous emphysema. So perfect. Yeah, this is kind of like a continuous hemidiaphragm. But yeah, you shouldn't be able to see the air under the heart. You should have a silhouette sign right there because the heart is sitting on the diaphragm. Next slide. Okay, so a lot of times you'll see, complete opacification of a hemithorax. The two most common causes are complete atelectasis or a massive pleural effusion, or big bloody effusion after trauma. What do you guys think about this one? Great, Jenna, why do you think it's why do you guys, or one of you who answered, why do you think it's a pleural effusion? Perfect. Right. Right. Jenna, how, you guys are totally smart. I don't need to teach you guys about radiographs. Definitely a pleural effusion. The trachea is shifted over to the other side. If this was atelectasis, the trachea would be, the mediastinum would be shifted towards the opacification. Next slide. So here's the kind of the difference. You can see the left lung atelectasis, like you guys aptly pointed out, the mediastinum shifted over to the left. And then in the massive pleural effusion, the mediastinum, the trachea are all shifted over away from the consolidation. Perfect. Next slide. Let's talk about pulmonary edema. First, before we talk about pulmonary edema, you guys still have your papers? Okay, we're gonna draw a secondary pulmonary lobule. The secondary pulmonary lobule is the smallest thing that you're gonna be able to see on CT. To do that, we're gonna draw just a little hexagon. You guys got that? This is just gonna be connective tissue. And then in the hexagon, running here, we got pulmonary venules. And then we also got some lymphatics running here. Then we got the pulmonary arteriole here. And then we got our bronchiole here. And then all around here, we're gonna have our little fluffy alveoli, just doing all our gas exchange. You guys got that? Let's see your beautiful drawings. Can you see my drawing, or is my big head in the way? Can you guys see that? Is it beautiful? I want to see Jenna's. She's smiling, but I don't see hers. Oh, that is beautiful. Tres belle. Perfect. The point I want to get across from this is when, anytime you have pressures, your capillary wedge pressure from the heart is increasing. Your lymphatics and your venous system is going to bulge out. It's going to leak. So the first thing you're going to get is these are going to increase in size, but it's going to be very smooth looking. If you see on a CT like smooth interlobular septal thickening, that's kind of the descriptive phrase that they use. That's more like pulmonary edema. But other things can have interlobular septal thickening too, like lymphangitic carcinomatosis, mycoplasma pneumonia. There's things that cause more like nodular septal thickening, but pulmonary edema, it's going to be very smooth. So that's kind of the first thing you're going to see. And this thickening right here is going to be what you guys have probably heard about, these curly B lines. When the pulmonary capillary wedge pressure gets even bigger, I think like over 25, then you're going to start seeing these alveoli fill up with fluid, and then you're going to see the fluffy airspace opacities and more of the pleural effusions. Great, you guys just drew your first secondary pulmonary lobule, and they're really cute things. Let's go to the next slide. So that's just kind of showing the capillary wedge pressure, what you're going to see. Peri-Bronchial cuffing is another thing that you can see. We'll show you on the next slide though. Maybe. Oh, there it is. So this is kind of just outlining the things you're going to see in heart failure. So just starting from the top, you're going to get cephalization of the pulmonary vasculature. So as there's increased pressures, usually you see a lot of vasculature down below and not as much up top, but you're going to start seeing more pressure pushing the vasculature up top. And then you're going to get this peri-bronchial cuffing, which is just bronchioles that have like little fluid, little edema around them. And then the curly B lines are the other thing that a lot of people talk about. And pleural effusions. We'll see the curly B lines on the next slide. A more, wow, that is a way better view of those curly B lines. Notice the normal radiograph. You shouldn't see really any pulmonary vascular markings about, I think it's like 2 centimeters out from the edge. Notice these vascular markings go all the way to the edge. Curly B lines, secondary